One of my main things that I do is hospital and ER follow-ups. With me being in the emergency room and having that background, it kind of does help me with that when I'm following up with these patients. The goal of that follow-up basically is to prevent them from going back to the hospital or going back to the ER. So we'll do like med reconciliation. I'll make sure that they got everything that they needed to get, whether or not they had home health, whether or not they need home health, whether or not maybe they need like a behavioral health specialist involved. Caitlyn she seems to really help me when it comes to like that aftercare, when it comes to the hospital follow-ups, especially if it's a psych patient, because we do have quite a few psych patients at our clinic. Chronic condition education is a big thing that I also do. I mainly do diabetic education. We used to have a diabetic educator that worked with us, but we no longer have her. So I do a lot of diabetic education. Record retrieval, this is like for our health maintenance. I request colonoscopies, mammograms, anything for health maintenance, I'll request it and then update their chart to reflect that. Quality metric reports, I run them pretty much every day. This is what I was talking about, certain metrics we have to meet throughout the year. A1Cs, that's a big metric. Controlling your diabetics with an A1C less than 9. Hypertension, that's a big one for our clinic, controlling our hypertensive patients. So I will run those reports and see who needs what needs to be done for that patient, and then try to intervene any way that we can. And then the CPC Plus is the program through Medicare that we're with. And then PCMH is actually the Medicaid program that we're with. So I do report to both of those programs with our metrics and things that they require for the year. And then we talked about the provider meetings and education for providers regarding this program. Like I said, we used to have once a week meetings with our providers, an hour meeting that we just discussed whatever we felt we needed to discuss, whether it be patients or the program. Now, we have a lot of times our providers have questions about that program or about certain things within the program. And that is my job to figure out the answers for them and let them know what they need to know. I also do pre-charting for our providers for health maintenance. Now, if I see a patient is due for an A1C, I will pre-chart and I'll let them know that. Or if I see that that patient may need a colonoscopy, I might notify that provider to go ahead and order it or to discuss it with the patient. And then any other clinical nursing needs within the clinic. Obviously with COVID last year, our staffing was a little bit low. So anything that needs to be done within the clinic nursing wise, I'll do that as well.
Okay, let's talk behavioral health integration. So well, there are several models that different clinics operate off of, but there really are about 3 levels of behavioral health integration. So you're at first, at the basic level, you're going to do at least care coordinated behavioral health care. And what that means is that you're doing business as usual, but you're doing care coordination with the behavioral health side specifically. So what that means, your primary care physicians are screening, they're starting meds for behavioral health, for antidepressants, things to help with anxiety. They're doing those things, and then they're referring out for care. Now, what's different with that is that the behavioral health referrals are specifically followed. So you've got the care manager specifically following these referrals out to their community resources, whether that's the community mental health care clinic or a private clinic. Either way, they spend time making sure that patient got from point A, which is your clinic, to point B, which is their resource, and were they served adequately there. So there's a lot of follow-up, making sure that their medicine is working and making sure that the care that they're receiving at that mental health resource is adequate. And then you go to the next level, which is co-located behavioral health, which is where you do have a licensed mental health professional in clinic, but you're not working necessarily as collaboratively as full integration. So again, your PCPs are going to be screening for behavioral health needs, starting medicine, and then they're able to refer to the mental health professional that is within their clinic. Now, these co-located behavioral health professionals are typically going to see your depression, your grief, your anxiety, but they also will take on some long-term clients. So you could be seeing some trauma, you could be seeing some bipolar disorder, things like that, that necessarily would be sent outside and resourced outside of the clinic. You've got the mental health professional in there that is going to be seeing them in-house for possibly a long-term period of time. And then you move on to the full integration. So full integration is when you have a licensed mental health professional in office and they're working off of a brief model, a brief intervention model. That means that they're able to come in for consult. So if that patient needs someone within the exam room, if they are identified by their PCP through screeners or by this rooming staff by screeners, you're able to bring that mental health professional in, let them have a conversation with that patient and come up with a plan. And then on the treatment side of that, you are also able to see patients for brief intervention. So in comparison to the co-located professional, you're just seeing the, like the depression, the anxiety, insomnia, some health behaviors that can be addressed within 4 to 6 sessions. And typically those sessions are about 30 to 45 minutes long. So there's a couple of different levels of behavioral health integration, and they all make change. They all do well. It just depends on what's best for your clinic. For me, I do full integration, and I'll go into that in just a minute. These are some example of care models. I don't want us to get bogged down here, but just a couple of examples is PCBH, which is something you may have heard, just kind of peripherally, which is primary care behavioral health. And that is when a mental health professional is fully integrated and is a core element of the staff in the primary care clinic. You also have collaborative care management, which is when there is a care manager that has been trained in mental health that is within the clinic, but they're not necessarily doing brief intervention. They really concentrate on following for medicine, consulting with the psychiatrist, and making sure the patient is able to get their needs in the community. And then, of course, an honorable mention here is screening SBIRT, which is screening, brief intervention, and referral for treatment. So that is not necessarily where you do have a mental health professional in office, but you are making a targeted approach to catching substance use disorders early and making sure that they are routed to the right person for treatment. Okay, so what is the goal of behavioral health integration? Well, my organization's goal of behavioral health integration is the quadruple aim. So you may have heard this as the triple aim, but we have added clinician experience to that. So of course, the main goal is improve overall health. We want our patients to do well. We want them to feel good, but we also want them to feel satisfied with their care, and we want our physicians and our staff to feel that same way. And then overall, if those things happen, we decrease the cost of care for the population. So I always think it is extremely important for not only our patients to be satisfied, but our physicians and staff to feel like they have the tools in order to treat all populations of care. All right, so why do we do integration? So there is a lot of evidence showing that integration is needed. So in one of the studies that I read was that general medical costs for people that have a chronic medical condition, but also a mental health need, has shown to be 3 times higher than just if they were addressing the physical health conditions. And that is probably due to the fragmented care in our country, where none of us are naive to know that it is sometimes hard to coordinate care for our patients, especially when they have several comorbidities. There's a study that was done in 2012, which I know now is a little dated, but I like the study, which is why I put that on there. It says comorbidities incurred an estimated $293 billion, which today in 2021, that's about $338 billion. Now, if you're like me, I stopped listening after 1 million, because 1 million and 1 billion mean about the same to me. So a lot is what it means. So that number is pretty astounding. This Milliman study that they put out last year in 2020 shows that if these mental health needs in patients are effectively addressed, they're more able to participate in the programs to help control their chronic medical illnesses. And that decreases the risk for new medical problems as well. I included some statistics here that I thought were pretty shocking. Now, this is not the first time I've heard it. I've heard it from another psychiatrist, but 5.7 of the entire study population, so the population that they used for this study, high cost patients with both conditions accounted for 44% of all healthcare spending. So that small chunk of patients is spending almost half of all healthcare spending. That's astronomical. And then within 50% of all patients with behavioral health conditions had less than $68 of total annual spending for behavioral health treatment. So you see, we're spending $338 billion a year, and what a minute amount that's actually being spent on mental health treatment. And that could mean that there's barriers to care, there's a stigma related to it, it's just too expensive. There's a lot of factors that go into that. All right, so with all of that, what does my day look like? What is my job? Well, with full integration, your day looks different every day you walk into the clinic. So one of the big things that I am used for is consultations. We also call these warm handoffs. So if a patient is identified through screening, the PHQ-9, GAD-7, the MDQ, anything like that, they pull me into the room if I'm available, and I talk with the patient, educate them on what their symptoms mean, talk with them about possibilities of medication, and then we talk about a treatment plan. If they're interested and are appropriate for brief intervention, I go ahead and schedule with them. So my scheduled appointments include treatment for depression, anxiety, insomnia, grief, health behaviors. I have several patients that want to quit smoking, and that is totally appropriate for this model, and I do help them with that. I'm also responsible for the psychoeducation of staff and patients. So not only am I educating the patients, but I'm also educating my providers and my staff that are working here in the clinic. Of course, in a primary care clinic, and specifically to ours, I work with an internal medicine doctor. So we see chronically ill patients. So they are across the spectrum. My staff is on what they have to remember. So it's only appropriate that I stay on top of the latest information in the mental health field, what's appropriate, what's the best screening technique, what's evidence-based, and share that with them as often as possible. I also do care management, and this is where the hybrid full integration that I do is. So I do a hybrid model of services where I do the care management piece as well. So if we have a patient that starts on a new medication and isn't really interested in therapy, or maybe just doesn't need therapy yet, just wants to try the medicine, I'm also alerted to them, and then I follow them for about 2 weeks, check in on that 2-week mark, make sure they're doing okay, make sure they understand their medicine and how long it's going to take to work, and then check in with them again in 2 weeks and continue to screen them ongoing. And then finally, crisis intervention. So my staff is trained to address patients that are having suicidal ideation or homicidal ideation. But if I'm available, they pull me in there and we talk about some treatment plans. Now, I'm a firm believer in not all hospitalizations are good hospitalizations. So we want to make sure that if there is a way that we can keep that patient stable and able to rapidly get them follow-up care, we do that as much as we can. We we work with them on a crisis response plan. We get them a rapid follow-up, whether it's with me or whether it's with an outside mental health resource. We just try to make sure that the patient is able to do everything they can before hospitalization has to happen. So now we'll go over some patient examples. We wanted to make sure we gave you guys some insight on how we collaborate and how these patients even come into our realm of knowing when we need to collaborate on. So did you want to present that one? Okay, so she's going to present that one this morning.
So me and Caitlyn, we had a 33-year-old female. She was undiagnosed bipolar. She did have uncontrolled type 2 diabetes. She was full-time employee. She had 3 young children at home, and she was a Medicaid patient. So there were some social determinants of health that she was needing. She met with Caitlyn first for education on her bipolar diagnosis. And then Caitlyn actually came to me and kind of let me know this patient, obviously her background, and then let me know her diabetes was uncontrolled. they worked with the provider. She switched her to an appropriate medication, and then also affordable diabetic medication. And then she maintained regular meetings with Caitlyn and both myself. In March of 2020, her A1C was at 8.6, averaging blood sugar about 250. And then January of 2021, her A1C was at 7.1, and her blood sugar was 120 to 150. She actually did say that she's had diabetes for years, and she said, "You all are the first to tell me how it works and what it does to my body." So just having that input from the patient lets us know that we're actually helping these patients. We're doing something, working together and determining the needs for these patients. We're actually doing something for them.
And I also think this example speaks to Sam's ability to kind of reach across any lines that are happening, because the way we got her on a affordable diabetes medication is Sam contacted her endocrinologist and said, "Hey, this patient's in our office. She's uncontrolled. She's trying her best, but it's just not working for her. What can we do in order to get her on a more affordable diabetes medication?" So not only were we able to collaborate in office, but Sam was able to reach out and say, "Hey, we identified this need. What can you do with us?" And thankfully her endocrinologist is it's in the same building. So it was easy to get in contact with. But I was just so surprised that this patient had diabetes for several years and had never been appropriately educated on it. So I guess I also say that speaks to how we should really pay attention to our patients' health literacy level as well while we're doing this work.
Yeah, I think a lot of times just having someone like us speak to the patient, we have such different backgrounds, so we may pick up on something that the doctor may not have, or vice versa or whatever. But I think it's always beneficial for just to have a conversation, and that's normally how I start my meetings off with my patients. I'll just have a conversation with them and get a feel for who they are and maybe how I can educate them best to where they will understand.
Okay, so our next example was a really sweet 77-year-old Caucasian female. She came in originally to speak with me about anxiety over the coronavirus. So this happened earlier last year. Of course, I screened her, and she came up on the GAD-7 with a number of 17, which is pretty significant anxiety. She met with me to go over some anxiety tips and exercises. So we taught her some grounding techniques, some breathing, and then some muscle relaxation, just to help her get through those really panicky times. And then after speaking with her, she had a lot of technical questions just about the virus and how it works with your body, and how do we disinfect, and how do we protect ourselves. And I thought to myself, well, I am not the right person to answer that question. So luckily Sam was available, and she came in and she sat down for 30 minutes and talked with my patient about how she can protect herself, and what her possibility of infection was, and just really helped answer all of her questions. So she came back in a month later, and we rescreened her, and she ended up having a decreased score of 8, which is a decrease of over 52%. And what came out of that was that she stayed engaged in her care, and she was willing to come in and see the provider despite of the pandemic. Now, of course, we had switched to telehealth mostly, but there are those patients that still need to come in for labs, and we're slowly transitioning back to seeing patients in clinic. So our main goal was, yes, to make her feel safe, to make her feel like she can control this anxiety and cope with it. But on the other side, we wanted to make sure she stayed engaged in her care. And thankfully, due to the collaboration, we were able to answer those questions for her.
This one was a fun one. We had a 55-year-old man. He actually presented to me for diabetic education. I believe that he was either newly diabetic or uncontrolled diabetic, but his A1C in February of 2020 was 9.7, which obviously was uncontrolled. So he initially met with me, and I did have that conversation with him, got to know him a little bit better. And during that meeting with him, I realized that not only would he benefit from my help, but he would really benefit from Caitlyn's help, because I could see that behavioral health, that mental aspect of it coming through very heavily. And like I said, I dealt with a lot of psych patients in the ER, so I do see it when it comes through, and I kind of get the vibe that something isn't right. So after speaking with him, I determined that maybe meeting with Caitlyn would be beneficial, and I did bring that up to him, and he was completely for it. And then got with Caitlyn, we discussed him, and then she got to meet with him, and he had recently lost his daughter, and him and his wife weren't really getting along very well. So Caitlyn really did help him there. And even the patient, after he had seen Caitlyn, he came and saw me again, and he was like, thank you so much for sending me to Caitlyn. She's helped me so much. I feel so much better. So I knew at that point that was obviously the right decision for him, and I knew Caitlyn would help him. And then back in May, just a few months later, his A1C was 6.9. So obviously us working together kind of helped him out there. So.
And we took some time to educate him on how his blood sugar level affects his mood. So, and I can't count how many patients that we have that will come in and say, you know, I feel depressed. My mood is always low. Or on the other side, I'm anxious all the time. And one of my first questions is, if they have diabetes, is okay, how often are you checking your blood sugar? And are we treating it appropriately? Are you taking your insulin? Are you taking your metformin? Those types of things, just to get an idea of, okay, what landscape are we starting with? Is that you do have true depression symptoms, but are they exacerbated by these uncontrolled diabetes symptoms? So honestly, it was just as simple as educating him on the grief process. He, even at 55 years old, had never lost someone that close to him, and it was a very sudden death. So he felt a very I would say not insecure, but his foundation, his security was rocked. So just educating him on grief and how that process is going to go for him, and then getting him connected to a support group. So being able to share his story and share his feelings and be validated by other people who have gone through it was very helpful in that. And like Sam said, you know, when we talked to him originally in February, he had a really high A1C, and his blood sugars were consistently 250 to 300. And one thing I didn't add in here is that he's a truck driver. So he's also not having access to the best cooked meals or the best time frame in order to plan those meals. So he's got a lot of that going on too. And then, you know, like Sam said, thankfully we were able to lower that almost 3 points. So he worked very hard on that. We're very proud of him for that too. So with these examples that we've gone over and what care coordination looks like in our clinic and what integrated behavioral health looks like in our clinic, we wanted to make sure we address that, okay, some of these care coordinators on this call don't have a BHC. So we wanted to make sure that we gave some resources to those that don't have a behavioral health consultant, because with the history that I have as being a care coordinator, and Sam herself being a care coordinator, we understand how much pressure is on you guys, especially with running this program and having to be pulled into rooms and talk with patients, and just wanting to make sure that you have the tools in order to do your job, which goes back to that quadruple aim, of course, of physician and staff satisfaction. So did you?
So there are some trainings.
Not yet, but Arkansas Behavioral Health our integration network does have some trainings already available on their website, especially a Kent Corso training on addressing suicide in primary care, which is just phenomenal and fits right into the model of, hey, we know your physician only has 10 minutes with these patients. Here's what we can do and how we do it safely. So that is available, and there will be more training coming.
And then these are things, this is what we're talking about, things to do if you do not have a behavioral health consultant within your clinic. Obviously, we want you to develop some type of relationship with your local mental health clinics, however you can do that, whether it be a care compact or maybe just a verbal agreement, anything like that. Some type of relationship, you need to build that relationship. Educational handouts, here's a couple of links here. You can get some handouts for patients if they come in your clinic with like SI, HI, any depression, anxiety. There are some handouts that you can give those patients from those websites. And obviously we want you to advocate for some type of integration for the BHI, whether it be fully integrated or just partially integrated, like what Caitlyn talked about earlier. It is honestly, without Caitlyn being here, I think the population of patients that we serve, we really needed a BHI, and I think Caitlyn was probably the best pick for this clinic. She does very well with it, but we work really well together at realizing what patients need our services and whether or not we can work together to help these patients. And I think us working together, as you can see from those patient examples, it really benefits our patients. And I don't think that the last patient we talked about, I don't think that he would have gotten his diabetes under control if it weren't for Caitlyn's help, because I saw that more than I saw his uncontrolled diabetes. I saw his mental health aspect was way, way more uncontrolled than his diabetes.
Okay, and for those behavioral health consultants on the call, so that want to engage with their care coordinator more, the very basic advice I can give is just look for every opportunity to engage with them. So if you are finding yourself Googling a disease process online and you need some more education for it, you go and ask your care coordinator, because now most of our care coordinators for our organization are going to be nurses, but you can come across other care coordinators that are dietitians, health educators, some of them are pharmacists. So there are some other disciplines that are involved in care coordination. But I say whatever their discipline is, go and ask them. Go and ask them just for that education. And I think that gives an opportunity for you both to learn what your learning styles are together and how to collaborate with each other. Another thing I suggest is attend routine clinic meetings. So I know the last thing we need is another meeting, but I do suggest asking to be invited to that high risk meeting. If your clinic is doing those, or if your clinic wants to start them, I would definitely involve as many disciplines as possible, because you're going to get a different take on everyone. And I can almost guarantee in these high risk meetings that we do, every single discipline, whether it's the dietitian or the pharmacist or me or the RN case manager, that we all get involved with something. There's always something, a piece of a patient that we can work with. I also suggest attending the care coordination meeting. So with our organization, we have a monthly care coordination meeting that doesn't necessarily require me to be there, but it is so enlightening on what my care coordinators are going through and what metrics they're trying to have to reach. So it lets me have a little bit more information on that. And then again, with the program metrics, you want to learn your program metrics. So not just for the ones that we're responsible for. Of course, I'm aware of the depression ones and the dementia ones and things like that. But you also want to see what other program metrics are they trying to make, which Sam alluded to a few minutes ago, that, we've got A1C, we got CHF, we have, I said A1C, diabetes. We have those things that we're trying to reach, and all of those things a behavioral health consultant can help with. And that goes right into that health behavior model. So those are our suggestions for the care coordinators that don't have a BHC and just need some more information. And then those are my recommendations for a behavioral health consultant that wants to work a little bit more collaboratively with their care coordinator. These are references for the studies that we used, in case anyone is interested in reading up on those. And then, of course, our contact is available if you guys have further questions. If you have questions just about mental health in general or care coordination in general, we are happy to answer those questions, and you can reach us there at our email. So I'm going to stop sharing for a moment so I can see what's going on. Okay, Kim, do you mind if we answer some questions now? Is that all right? I know we're a little ahead of time.
That would be great. That would be wonderful. Let's see, do we have any questions in the chat? And if not, we can go ahead and just take questions.
I don't think I see any in the chat, but I'm happy to answer the verbal ones.
Over there.
Dr. Jansen.
I've got a question, couple questions. I used to be with AHG in the past. I remember that now after texting back and forth with Dr. Gibson. So, AHG has clinics all over the state. Y'all are doing a great job at the Otter Creek Clinic. I understand the criticality of being live on the ground, warm handoffs, elbow bumps, if not handshakes right now, whatever, with COVID. But Baptist is also, they've been a little bit progressive in the telehealth space. And so I'm wondering if there's been any discussion in the AHG system about trying to create a virtual integrated behavioral health care system where you have centrally located case care managers as well as LCSWs that could assist the more rural parts of the AHG network with a virtual integrated program.
Good question. And it's funny that you asked that now, because that has been discussed in the last couple of months. It has not come to a planning place yet, but we are looking to hire, and we're just trying to make sure that that we have the telehealth capability in all our clinics. Now, most of them have it, but going out and making sure that they have the cameras and the internet to support it. It has been discussed. Right now, of course, we only have about 6 clinics that have behavioral health consultants in it, but that is an idea that we have considered. And I'm glad you asked that question, so because it sounds like there's interest in it and that it would be pretty helpful. So yeah, we have considered it. Has not been planned yet.
And the other problem that I saw back in the day was, with case coordination, care coordination, trying to do all the gap closures, not just the behavioral health component, but all the different quality metrics you mentioned, A1C, colonoscopy, vaccinations. The problem I think has been there's just no repository of data that you can cross-reference. And it's been so hard. I know Herb's on the call, that when we were in our ACO, Herb, you remember that was always a problem we had with that, was trying to, if somebody looked like they had not had an appropriate screen or study, be it behavioral health or colon cancer or what have you, there was no central repository of information to be able to go back and cross-reference. And I'm out of that world a little bit now, but didn't know, Sam, if y'all had gotten any closer to the holy grail of cross-referencing for care gap closure.
Yeah, so it gets better every year, obviously, with this program, especially in our clinic. It's taken some time to actually even get that flow down of what we need to do and how we need to go about this. I just got integrated into the clinic about 1.5 years ago in this position as a care coordinator. Before that, we didn't have an integrated care coordinator, so it was a little bit difficult starting out. I have to get all of these records initially to just get a baseline of where we're even at, and then just every year we work on how to get better and do better. It's a learning process, and as I feel like as long as the physicians are on board and they're okay with doing whatever they have to do to get these metrics met, as long as we're working as a team, then it will get done. And I think that our numbers have definitely improved. Obviously, last year was kind of a difficult year to measure things, but it's definitely improved last year. And that's kind of surprising with the year that we had. Some of our numbers actually look better than they did the year before. So I think it's just 1 year at a time, and it's a slow process.
To your point, Dr. Jansen, some of the behavioral health information, whether it's diagnoses, records, or medications, also gets treated variously as protected. So it isn't necessarily easy to flow from, obviously you guys, if you're integrated, fully integrated, you're in the same clinic, HIPAA is not a problem. But trying to get this information to flow to other providers or consultants or something isn't always the easiest thing to do. And even some of the data that we're able to get from different commercial payers is hampered by restrictions on what can you say about this patient. And so I think we're going to make progress there, but that has been a stumbling block for integrating this kind of information better than it has been.
That's a great point. That's an area I think to all continue to work on in future exchange of health information, and practice can use care contract agreements to be able to communicate with specialists you may refer to often. And one of the things that the specialty health providers have traditionally been extremely worried about confidentiality, and there's been kind of an overemphasis on we can't tell you anything. But if you really look at the HIPAA laws, and that they do not restrict communication between mutual providers. So if Sam had sent a patient to a psychiatrist or a therapist, that system could talk to Sam just because she is part of the treatment team. But oftentimes the specialists don't know this. So that's the group we also need to bring in to integration, is that many patients are still going to get care in the specialty offices, but we still need to promote and bring them into this because they're working hard over there. There's not enough of them. And so they aren't able to keep up with all of these changes, and they're trying to protect their patients and, make sure that they will come back. So I think that's a great area for us to continue communicating, and a place to reach out is bring in our specialists.
Yeah, and Dr. Gibson, that was definitely an issue when I first started in the position, because the care coordinator before me wasn't integrated. So it was difficult to break that communication barrier between us and the specialists that we're sending our patients to. But I think as the years have gone on, it's gotten easier and easier to access those records. Once they see it's coming from our office and they recognize my name or they recognize our docs, then they'll be like, okay, I understand this is their primary care, so I'm going to go ahead and send it. Half the time I don't even get a request for a release of information. I'll just do it through Epic, and it looks professional, and it goes ahead and sends it via fax, and it looks professional. So half the time they don't even ask me for an ROI. They go ahead and send the information to me.
One that speaks to the relationship building that you have spent time cultivating.
Yeah.
And I think it's also worth mentioning that Dr. Gibson brought up a good point, is that they're doing good work. These specialists are doing good work, but they're also inundated right now. I mean, I know we have all seen the studies, especially with mental health, on the increase of people experiencing those mental health symptoms. And now not all of them are going to seek care, but especially somewhere like Little Rock, I mean, we live in a metro area, but honestly, Arkansas is still small, and we have a limited amount of resource when it comes to behavioral health clinicians and resources for that. So not only are we running into the HIPAA part of it, but we're just running into a staffing issue. Sometimes they just don't have enough time in a day to send us those records as well. So hopefully that alleviates as we go forward, as we continue to educate our primary care clinics to take on some of that burden, as opposed to all our specialist clinics having to do that. But I think it's worth mentioning that not just HIPAA, but it's also, the fact that they're just so stinking busy. So.
And another thing that we've worked on since I've been here is updating that patient's care team within Epic, because a lot of our patients have a lot of specialists. I'm talking 5, 6 plus specialists. So working on updating their chart and making it, to where we know exactly who they're seeing for what specialty, that has been really important, because with Epic, you can communicate within Epic to those specialists. And they can see everything that you do, and you can see what they do. Certain specialists, obviously, who use Epic. But that has been a really, really big thing for us, is making sure their chart is up to date with who they see.
Which is also something that the behavioral health consultants can do as well, because your patients are coming in, and yes, we're intentional, we're strategic with our time. We spend a lot of time talking about exercises and how to cope with behavioral health needs, but they are going to mention, especially if they're chatting, hey, I went and saw my cardiologist, last week, and everything's fine. And, it's simple. Hey, who is your cardiologist? Let me put that on your care team. Will help the rest of the staff that you have in your office as well, to cut down on the guesswork that comes with some of this.
I think that there's, to my mind anyway, being old school, there's a certain degree of human intimacy to a physical visit, in the office personally. But it seems that the clinicians have become much more agile with virtual platforms, and are more efficient at getting on, being able to connect, and not struggling with the tech for 15 minutes into a visit so that's been a big help. But it also seems that the population at large has gotten a lot better at this. Even older people who've had to visit their grandchildren with Zoom meetings and things like that, or FaceTime. And so have you had any experience, now that we're almost a year into the public health emergency, do you feel like there's going to be a significantly increased place for the virtual care to expand because that, with the paucity of trained behavioral health clinicians, it seems to me logical, just from an operational standpoint, to be able to exercise that.
Absolutely. I think that that can only get better. You know, we serve, like I said, a large population of chronically ill patients, and a lot of them are considered elderly. And we have been so surprised at the patients that are willing to sign up for MyChart and willing to click that link and see their doctor on their phone. So not only does that speak to the primary care part of it, but also behavioral health. I think that addresses some of the social determinants of health barriers that we see, as far as I don't have the gas money to get there, I don't have the transportation to get there, things like that. We're able to go into their home. Now, like you said, I think a physical meeting is best. I always think that's going to be the top tier best intervention. But if we can go into their homes and see them, that's going to lessen stigma. That's going to make it easier just to address it. And so I think it can only get better. And some of the chattering that I hear from my therapist colleagues is that there's a lot of advocating with the payers to say, hey, let's extend this benefit. Let's keep going with it. Look how well it's going in the middle of a pandemic. So I do think there's room for improvement, but I think it's going well so far.
Thank you.
There's been good evidence in the mental health community that it is safe and it is effective to provide mental health care virtually. Of course, we'd always rather be in person, but it's been shown to be safe and effective to use televideo or even telephone in certain situations and contexts that works. So hopefully we will be able to offer it, because one of the barriers is being paid, because providers can only do what they can get reimbursed for. The other thing is the opportunity to have consultations, like perhaps a face-to-face with your specialist. So I'm glad that y'all are bringing it up. I put in a link to a webinar. The AMA BHI Collaborative did have a presentation of a practice in Colorado that was doing behavioral health integration virtually. And they would even do warm handoffs. The PCP would see a patient, and then their BHC would be ready, and you could bring them in, they could all three meet, and then the PCP could leave. So there's definitely a precedent for that, and it can work, and we can learn from people who are already doing it.
I have a question for you, Sam. My question is, and this is off the telehealth subject, but you said that you work in an emergency room sometimes, and you also work doing care coordination. Have you noticed there's also a need in the work that you're doing in your other situation for mental health? And do you think that it would be beneficial if you had access to a behavioral health consultant in that setting as well?
In the emergency setting?
Mm-hmm.
Yes, absolutely. Obviously, we know it's an issue. Mental health treatment with our country is a huge issue because there's not enough resources, especially in the emergency room. When I go and work the emergency room, 100% of the time, I'm going to get a psych patient. If I don't get it, my partner's going to get it. There's always psych patients in the ER, and there are only just a couple of psych beds in the ER. So it is very limited, the resources that we have. And a lot of times the patients that I see in the ER aren't really psych patients. They're more of patients that need somewhere to sleep or need somewhere to eat or something like that, somewhere to stay warm. And it's very unfortunate, but in those instances, we can't really do much for that patient because it is an emergency room and we're here for emergencies. And although we want to help them, we don't really have the resources to. So yes, of course, absolutely. There needs to be some type of behavioral health integration in the hospital systems. Yes, we do have behavioral health in the hospital, but it's only for, specific instances, and it's not for every single patient that walks through that door. And I would say about 50% of those patients probably aren't even psych patients.
Okay. Thank you. I was just curious. We have a few minutes for a couple more questions. one of the things I just wanted to say, I am so grateful that you all did this presentation today. For me, it gives a little snapshot into a day of the life and the importance of the relationship between the whole care team. And so every person on the team has an essential role, and you demonstrated that very well through your case examples. It's exciting. It makes me think, wow, when we look at the pieces working together and everyone gelling, the wonderful patient outcomes we're getting.
I mean, yeah, absolutely. And I just a tiny bit of self-disclosure here is I never saw myself becoming a therapist into social work. So this type of setting is just so interesting to me. I really get to be a part of somebody's medical treatment team. And I think that being able to do brief intervention is where what really works. Brief intervention is such a proactive approach to somebody's health that I'm just excited to have the opportunity to work in the primary care setting and be able to work with a care coordinator who is able to come in and educate on the disease processes that I'm not able to do so. So I think I'm just so happy. I'm just so happy to be here.
I'm glad you found your spot. You know, life is what happens while we were making other plans. So
True.
Absolutely.
I have a question. I'm Cynthia Kesterson. I'm a care coordinator for Lofton Family Clinic. We are in CPC as well. And I'm curious if you have seen, or what kind of impact you've seen with your ED utilization after behavioral health integration, because I love the data that you provided about that very small subgroup, that subpopulation that is making up such a big portion of cost for Medicare. And I see a lot of it with mental health in the ER. So many of our patients that a lot of their primary issues are really mental health related, but it almost always manifests as overuse in the emergency room. So what kind of improvement have you seen?
Well, I think we have quite a few psych patients that Caitlyn already sees. So if I see a patient maybe that Caitlyn has seen that is going to the ER, maybe more than they should for things that aren't, relevant to the ER, I might go ahead and say, hey, Caitlyn, I know you've seen this patient before. It looks like, something's going on. Will you reach out to them? Because I know you've already built that rapport with them. So that makes it easier in that sense whenever a patient that she's already seen is seen in the ER, and I can just send them her way because she already knows about that patient. But if I see a patient that maybe she's never seen before that goes in for SI or HI or anything like that, anxiety or depression, or they went in for chest pain and I know it's not cardiac related, it's probably anxiety, then I might say, well, when I call that patient and do that ER follow-up, I might say, well, we actually have a social worker that works with us in the clinic, and I think maybe she would be really beneficial to you. Is that something you would be interested in? And then that's a way for me to refer that patient to Caitlyn. And in that sense, it does make it easier. And I think that those patients pretty much benefit from seeing Caitlyn at that point, because for the most part, I don't see them back in the ER for that same symptom again. Now, obviously, our patients that have severe anxiety and severe depression and things like that, they will utilize the ER more than they should. But I think Caitlyn does help with that. I think if she wasn't here, they probably would be in the ER every week.
Wow, I made it through the whole presentation without doing that. Okay, we're good now. All right. So as far as data showing the a decrease in ER utilization, our program is still pretty young, so we have not been able to utilize the EHR to really reflect that. However, like to Sam's point, we have seen a decrease in those patients, especially anxiety patients that are going in with chest pain or chest pressure and things like that. Not even necessarily SI. We have seen a decrease in that because they've been educated on calling your primary care physician first if it's within hours, or calling that, emergency clinic number, like the medical exchange we have up here, the after hours number. So we have seen a decrease, but I'm sorry, I'm not able to give you data because I'm definitely one of those people that enjoys that. But as far as like anxiety or things like that, I would say there has been a significant decrease in those. Now in SI and HI, we honestly don't have a whole lot of patients that end up, and I think it goes along the lines of, here's what you can do until you need to get to the ER kind of thing.
I think it helps to them knowing that Caitlyn is here and they don't have to go to the ER if they're having an anxiety spell or a depression bout of things. I mean, they can just call our clinic and talk to Caitlyn, and then they may feel better and they may feel like they don't need to go to the ER. So just having her just here for the patient, I think, is beneficial in itself.
Okay, well, it is right at 9 o'clock. I want to thank you both. This was an absolutely amazing presentation. I think we got such a snapshot into the importance of the care coordinator and behavioral health consultant working together, and how these roles really can enhance patient care, decrease costs, decrease utilization. And so this is exciting. You demonstrated very, very nicely how these roles help manage the patient and address the quadruple aim. We appreciate everyone getting out this morning on an icy cold Arkansas morning. We know it was early. I apologize, I had a few technical issues in the beginning. Thank you for your patience with us, and we want to be respectful of your time. We will see you actually in March. We're going to be doing a presentation with the TMF folks. It'll be a 3-part series. So look forward to an invitation for that in March, and we'll be seeing you back here in April. Take care.
Bye.